Afternoon, my name is Tyson Lehman. I'm here to review distributive shock secondary to anaphylaxis. It's come to the group's attention that there's a paucity of knowledge on the management of distributive shock secondary to anaphylaxis, and this clinical update will seek to explore distributive shock secondary to anaphylaxis. Our outcomes, we're going to review the definitions and epidemiology. We'll look at the pathophysiology, some clinical features. We'll look at review the differential diagnostic focus, the physical examination findings when presented with distributive shock secondary to anaphylaxis. We'll review the pharmacological interventions. We'll visit some transport decision-making priorities, and we'll explore the clinical leadership responsibility. Traditionally, we have associated anaphylaxis with a systemic reaction and allergic response as a local reaction, but we should dive a little bit deeper for the group. The definitions, there's a variability of definitions out there. The World Allergy Organization versus the World Health Organization and the EAACI, which is a European group exploring the epidemiology of anaphylaxis. However, they all agree that anaphylaxis has a rapid onset. However, they vary on their specifics of number of symptoms required for the diagnosis. Therefore, the clinician must explore their demographic for their own geographic region, as we will do for North America and Canada. So looking, many define anaphylaxis as a life-threatening reaction. However, the data from large case series and patient registries has demonstrated that despite the fact that the vast majority of anaphylactic reactions are not treated appropriately with epinephrine, generally doesn't result in an increased mortality or morbidity. And this observation is also consistent with our national epidemiological data for food anaphylaxis, which indicate fatal anaphylaxis is a rare but unpredictable event. And looking at this survey-based approach or literature that reviews over 26 million cases of anaphylaxis in North America, that's over 10% of the population. You'll see that pediatric mortality is quite low, less than 1%, and that mortality is associated with milk, peanuts, and blood products. The demographic, adults, 24% of that population reports a epinephrine administration, but only 38 report emergency department visit. Pediatrics, anaphylaxis is associated in males younger than 13 years of age and females greater than 13 years of age. And then in the Asian subgroup, those children less than 2 years of age, the predominant trigger is food. There are 4 types of hypersensitivity reactions. Type 1 is our most commonly presented pre-hospital anaphylaxis. Type 2 is a cytological reaction or antibody-dependent. Type 3 is an immune complex reaction. And then type 4 is a cell-mediated or a delayed hypersensitivity reaction, like we see in So hypersensitivity reactions, again, type 1 immediate hypersensitivity or anaphylactic reactions are the most common, and we are well versed in this in the pre-hospital environment. This is due to anaphylaxis being the most severe presentation of an IgA-mediated reaction. And these lead to death from either airway obstruction secondary to tissue edema or hemodynamic collapse secondary to distributive. And in defining distributive shock, we're familiar with it. We see it regularly amongst our septic and trauma patients, although it's not always at the forefront of our minds when preparing mentally to respond to an allergy call. Distributive shock is also known, as vasodilatory shock, and it's one of the 4 broad classifications of disorders that cause inadequate tissue perfusion. This systemic vasodilation leads to decreased blood flow to the brain, heart, and kidneys, causing damage to the vital organs. Distributive shock also leads to a leakage of fluid from the capillaries and the surrounding tissue, further complicating this clinical picture. Triggers, the most common triggers in this subset reported in the literature. It's quite a large collection of 4,100 anaphylactoid reactions. Insect rubites responsible for 50%, foods are responsible for 25%, and then drug reactions are responsible for 15%. In adult presentations, traditionally we expect to see rash, hives, and urticaria, but they're only present in 80% of patients. So 20% of your patient subgroup may never develop hives or manifest in other compromise of other systems, i.e. isolated airway or hypertension. GI symptoms such as pain, nausea, and vomiting, or incontinence are often under-recognized or undervalued in the anaphylactic presentation, are indicative of systemic involvement. And of course, shorter breath and or hypertension is an ominous sign in And exploring distributive shock secondary to anaphylaxis, particularly in the adults, you'll see an altered LOC. You'll see a profoundly diaphoretic patient. You may or may not see incontinence of either urine or stool, tachypnea and tachycardia. All these presentations you'll see in a progression of their illness, and it'll depend on what first aid or first interventions they've received. And the sicker the patient becomes, the spectrum, you'll see their therapeutic. In your pediatric population, using the pediatric assessment trial, it'll allow you to quickly and effectively match a history of contact with the symptoms for you to act. And this is a low systolic blood pressure, which is age-specific based on the calculation that you use, and or a decrease in your systemic systolic blood pressure greater than 30% after you. Campbell and Kelso provide us with our guiding approach to the diagnosis of anaphylaxis, our geographic region and our organization. And this guideline utilizes the following 3 steps. A sudden onset involving either skin and or mucosa, or two or more symptoms that appear suddenly after a known exposure, or 3, reduced blood pressure after exposure to a known allergen. Some differential diagnosis for you: consider a MI, or what might be looking like a myocardial infarction, although it is secondary to anaphylaxis, which is Kuhn syndrome. You may see some idiopathic or non-IgE mediated drug reactions, or classically see what you may see as a vasovagal, which is the most common imitator for distributive shock secondary to anaphylaxis in your hypertensive and bradycardic patient. The evidence points to some significant under-triaging and under-treatment of confirmed anaphylaxis cases. 2 Canadian studies, one by Kimchi, presented that 35% of patients, and then by Welsford et al., presented 41% of cases of confirmed anaphylaxis that did not receive epinephrine prehospitally. However, the more severe the symptoms, the more likely the patient is to receive epinephrine. And the literature supports here nearly 70% of near-fatal reactions in the emergency department were treated by pre-hospital epinephrine. And the basic life support tenets within our approach to anaphylaxis include: 1, removing the trigger or changing the environment, positioning your patient supine to maximize or mitigate hemodynamic compromise, awareness of ABCs, caution with intubation with a negative hemodynamic effect that has, be prepared for cricothyroidotomy if required, and or be cautioned of positive pressure ventilations due to its increased intrathoracic pressure and negative effects on hemodynamics. Ensure you have all your telemetry up, SpO2, BP, SpO2, and live electrocardiography, and then ensuring access, IV or intraosseous access. And throughout this, the whole time, focusing on the early and concurrent management, intramuscular administration of epinephrine. And the senior clinician should confirm these steps have been undertaken, establish a priority of intervention based on what has been initiated prior to your arrival on senior clinician. Reiterating some of the key clinical investigations when presented with distributive shock secondary anaphylaxis. First-line pharmacology is epinephrine. This is the first-line treatment in anaphylaxis, is well supported in all the evidence. Epinephrine has both antihistaminic and mast stabilizing priorities, also well supported in the evidence. However, some of the things that we can continue to educate our colleagues with, or bust the myth of Benadryl. Benadryl is reserved, or diphenhydramine, is reserved for our allergic reaction patients, and it's not indicated in life-threatening anaphylaxis due to its delayed onset of action. There is some support literature to support or suggest that magnesium mitigates immune stress response and protects from myelitis secondary to anaphylaxis, as you see in Kuhn syndrome. And there's also some evidence to support that it delays secondary or biphasic reaction. Although this is not a frontline medication, as used in other respiratory illnesses, it is a secondary line agent or a tertiary. So reviewing, IM intramuscular epinephrine 0.3 to 0.5 milligrams every 5 minutes to a maximum of 3 doses is our guiding philosophy here within our organization. And this is the evidence that is considered best practice for our service. And the evidence supports that the vastus lateralis IM epinephrine achieves a 6-time higher peak serum concentration than deltoid or other common intramuscular sites. So there is some literature there to support your location for intramuscular injections. And now Auto-injectors are predominant in the public setting, and check first for first responder use. Think about the appropriate administration method, the site, if it's been done correctly, and if it has yet to be used and is available whilst you're preparing your medications, it is appropriate to administer these auto-injectors. When considering fluid resuscitation, the following approaches should be considered. One, we need to ask ourselves, do I need the fluid? Is the patient hypoperfused? And is there evidence of fluid depletion? Or do I need the tone with no evidence of fluid depletion or dehydration or fluid loss? If fluid is required and a fluid challenge is indicate, we're going to correct hypoperfusion and achieving a systolic blood pressure of 90 millimeters of mercury up to 2 liters in 500 ml increments and reassessing at regular intervals for any development of pulmonary edema. And if you require or require arterial venous tone, concurrent administration of IM epinephrine. This is a slide summarizing the basic interventions that should have been provided by your colleagues prior to your arrival in a tiered and targeted layered core environment as a CBN. If the IM administration of epinephrine is not producing results for your colleagues, then move to an intravenous intraosseous epinephrine is appropriate. It's administered in 50 to 100 microgram increments. And then any further refractory symptoms and a presence of beta blockers may warrant the use of an administration of glucagon. And the clinical evidence behind that relates to glucagon administration in refractory anaphylaxis. Although it's limited to case reports only, these case reports identify that hypertensive patients in anaphylaxis have an increase in blood pressure when glucagon is being administered following failed attempts with both epinephrine and fluid. Therefore, the recommendation is that patients who are on beta blockers are the most likely patients to respond to glucagon treatment and therefore receive the most benefit. Again, this slide summarizes our supported interventional guidelines as discussed. There is consideration for rebound and biphasic reactions, although are limited to the pre-hospital environment since we spend such a short amount of time with our critically ill patients. There is more of a consideration for our medevac and retrieval colleagues who may be transporting those patients resistant to resuscitative efforts to larger tertiary care centres. And these are rebound or relapse. They generally occur 4 to 12 hours post-reaction and most often associated with oral ingestion. And despite the liberal use of corticosteroids, there is no quality evidence to support this intervention, although the investigation will further dive into the use of corticosteroids in anaphylaxis beyond the scope of this presentation. So transport decisions, we should be staying in plane. We should resuscitate, differentiate, and communicate. We've got to gather our team. We should summarize what is known and the plan moving forward. We should review our destination guidelines and any diversion criteria to get our patients to the appropriate facilities. And if you don't have the tools required or the pharmacology required, get them started towards you or start moving towards them. And our clinical leadership responsibilities as a senior clinician on the scene is firstly identify yourself upon arrival and receive a clinical update. Maintain a lens for your own bias and awareness of under triage as reported in the evidence. Ensure epinephrine is being considered or administered early. Ensure you articulate the critical status of your hypoperfusing patient to the team, especially distributive shock secondary to anaphylaxis. Adopt an aggressive clinical management approach to your patient. If required or unsure, call a friend. Reach out to your critical care team or your online physician consult if required. And ensure that your patient is advocated for by pre-notifying to your receiving facility. In summary, anaphylaxis can lead to death, but even so, rates of diagnosis and levels of treatment remain low. And not understanding that anaphylaxis covers more than simply anaphylactic shock, and that treating the disorder depends on identifying the syndrome rapidly and stopping by the judicious use of epinephrine, the potentially lethal cardiovascular and respiratory complications secondary to anaphylaxis. Thank you very much for participating in this deep dive into the identification and management of distributive shock secondary to anaphylaxis, and I look forward to answering any questions that you may have. Thank you very much.